Thank you, TNOA and AIOS for this opportunity. And there's a lot to say in the medical management of glaucoma and what's new and what are the current perspectives and how to escalate management in terms of medical management for glaucoma as the talk today. So we all know that glaucoma is managed by reducing intraocular pressure. And how do we decide what medication, how much to do and how much to give a given patient is to categorize the severity of glaucoma, categorize the risk, set a target pressure for a given eye of a given patient and then choose the medication. So how do we choose the medication? You go for a higher target when the damage is early, when the life expectancy is short and the damage that occurred is high. Similarly, we lower the target when there's advanced damage and life expectancy young patients and when the IOP at which the damage occurred is low. So all of these helps us decide as to tailoring a target to a given patient. And we have to keep in mind various aspects of glaucoma management, that is the tolerability of the drug, the long-term IOP efficacy, the cost, the adherence. Will the patient follow something like pilocarpine given 4 times a day or prostaglandin given once a day and so on. Long-term efficacy, long-term safety, and how does the drug work? I mean, in the sense, if you're giving a drug which is going to work 20% lowering of IOP as compared to what can work at 35% lowering of IOP, all this has to be in mind when you're deciding the target pressure. First-line drugs commonly have been, like in the past, beta blockers. Now we all moved to prostaglandin as the choice. Every patient almost gets a prostaglandin now. We sometimes give a beta blocker for some issues other than when the prostaglandin cannot be prescribed for some reason. Second line drugs include, if you're given a PGA, you add a beta blocker. You also have alpha agonists, topical CA inhibitors, pilocarpine. Now the new kid on the block is the ROCK inhibitors. Fixed combinations are very convenient for most patients because about 1/2 of our glaucoma patients, one drug is not enough. So we need to give more than one drug. So we need to add a drug, and giving an additional drug as an adjunct is also convenient to have 2 drugs in the same bottle. So convenience of dosing with a single bottle obviously improves compliance, adherence, and decreases the risk of washout when you put multiple medication. The back or the preservative in the medication reduces when you're giving a combination. Decreases allergy rate, decreases the hyperemia if you're giving brimonidine with timolol, for example. The hyperemia rate is much less. And also we must remember that almost all of them have timolol. So whenever you can't give timolol, you have to reconsider the combination itself. And dosing compromise is a disadvantage because suppose you want to give timolol twice and a beta blocker and the prostaglandin once, we are going to give a combination with the prostaglandin and timolol, you're giving it only once. So there's a dosing compromise, and some believe that timolol doesn't work at night. So dosing compromise is there, which is why some countries have not approved prostaglandin timolol combination in even the US, for example. So currently available fixed combinations include the prostaglandin with timolol, pilocarpine, dorzolamide, brimonidine. You also have a beta-free brimonidine brinzolamide, which doesn't have a beta blocker. And we now have the world's first triple drug. Triple drug is beta blocker, brimonidine, brinzolamide combination, which has actually become very popular now. We are quite surprised at the logic and the way we thought it would or would not work. But we do find it's extremely useful in practice. It hugely improves compliance, particularly, and then the IOP lowering efficacy is fantastic. So we get 30-35% drop in the IOP. And of course, we have the Rho kinase inhibitors with timolol. I think the one in India that's available is ripasudil with timolol. The triple combination, many publications including a multicenter open label phase 3 trial in India has shown the IOP lowering anywhere between 35 to 50% lowering intraocular pressure with one single drug. And this is a winner because we really been enjoying the benefit of not giving 3 bottles to a patient, 2 bottles to a patient. And this particular company, I think, has revolutionized the world's first triple combination, at least available now in India. ROCK inhibitors reduce the intraocular pressure by increasing the aqueous humor outflow through the trabecular meshwork primarily. And we have ripasudil, netasudil, and various combinations also. And they are basically serine, threonine protein kinases expressed in the trabecular meshwork. And the ROCK inhibition decreases the actin-myosin-driven cellular contraction and thereby reduces the production of the fibrotic ECM proteins, which alters permeability of the Schlemm's canal endothelial cells and morphology of trabecular meshwork cells. For all those of you who want to know the pathophysiology, how it works. So in simple terminology, it improves outflow through the trabecular meshwork. It's a trabecular outflow drug. And besides the increase in the aqueous outflow and then decrease in the intraocular pressure, it is also said to have a role in neuroprotection It helps in patients who have undergone glaucoma filtering surgery. Any bleb fibrosis, I generally prefer to give a drug like ROC inhibitor, in which T1 fibrosis is reduced in somebody who's getting fibrotic blebs. I would prefer to give a ROC inhibitor. And similarly, there is some advantage of giving these kind of drugs in patients with corneal problems, because the endothelial cell density sort of improves with the use of the ROC inhibitor. So you have multiple mechanisms of action, multiple utilities in terms of a glaucoma patient, especially in people with corneal problems. I prefer and lean towards these kind of, rather than giving a CA inhibitor, I would probably give a ripasudil, like a netasudil kind of drug. The mean IOP lowering was about 5.5 in phase 2, phase 3 trials, with both netasudil once daily and ripasudil twice daily. But mind you, the ripasudil, netasudil kind of drugs are never given as first line drugs, usually second line, third line drugs. By the time you already decided on operating on this patient and going in for a surgical procedure. So generally they are third line and maybe in fourth line drugs. The more number of drugs you add to medication in glaucoma management, you will find the efficacy of a single drug given alone is different from a third and a fourth drug added on to a pile of already existing drugs. So the efficacy tends to drop. You won't really get a huge drop in IOP if you're giving, let us say, more than 3 drugs or 4 drugs. So it's usually never more than 2 bottles, maybe 2 or 3 combinations at the most. 2 bottles or more is the limit for medication in glaucoma management. Beyond that, you should think of SLT, think of some other surgical management, go for a mixed procedure or go in for trabeculectomy and so on. There's so many options now available. So beyond 2 bottles, no. And this is a problem with netasudil in particular. Ripasudil also, invariably you end up with these hyperemia and perilimbal hemorrhages. You also start seeing these kind of things in the honeycombing in the cornea, which is reversible when you stop it, of course. But again, this is a worry. Once this happens, you cannot continue these drugs for this patient. And the new, again, what's available in India is a completely PF, preservative-free medication. This is also new. This is a big advantage for many patients. We also have 2 technologies in the PF bottles which are now available. One is called as the Novelia bottle. The other one is Aptar Pharmacy makes these Aptar bottles. I think Cipla makes Aptar. Many other companies use the Novelia formulations. They are very nice and very useful. The benefits of PF glaucoma therapy being preventing ocular surface inflammation, reducing side effect of preservatives, increasing adherence, and of course improves patients' quality of life and ocular discomfort. So all of these advantages of PF. And moving on to what's new again in glaucoma medication. These are the ones which were there in the past. I think some of us who are older generation glaucoma practitioners would have heard of this pilocarpine insert called OcuCert. This is all quiz questions for PGs who are here. But we don't use this anymore. We have now the newer formulation which can come in as a punctal insert, come in as silicone rings where you can implant bimetoprost, give travoprost in a implant which is kept into the punctum and so on. This is new, this is FDA approved, and this is a bimetoprost implant. This is actually a small pellet like thing. People who have seen Ozurdex, this is similar to the Ozurdex kind of implant in which you actually implant it into the anterior chamber. And it's first approved by the FDA a few years ago. Biodegradable polymer designed to release bimetoprost over a 3-month period. So what happens after 3 months? Can you inject it again? We don't really know, because the approval is only for 1 injection. We don't know how many more injections we can give, what's going to the patient, happen to the patient subsequently. This is a video which is available on the YouTube. It's just how the injection is given into the anterior chamber. In the interest of time, I'll move on to the last slide here. This is called as the, for people who have heard about the eye stent, you know how what is called as the eye dose. The eye dose is actually similar to the eye stent. You stent the trabecular meshwork like this. You put in the drug elutes from the stent which is kept here. This is made by the same company which makes the eye stent. It's called the eye dose. You have a travoprost which can come through the drug. So it's a titanium implant and elutes the drug with a therapeutic window of about 6 months. So issues to resolve with all of these implants, cost and availability, it's going to be a huge cost. Injection related complications, you're going to inject into the anterior chamber or in the angle, cataracts, endothelial issues, corneal problems. What about multiple medication? Can you just give 1 drug alone? What about repeat injection? So many questions that come up to mind. So you have to understand that we are making a paradigm shift in the way we are delivering drugs to the eye, choice of the drugs which you are giving to the patient, preservative-free combinations, and drug delivery systems are also changing. So would we shift away from glaucoma drops? We have to wait and see. Thank you all.
Thank you, Murali, for a wonderful, really wonderful talk. I just have a couple of questions. One is this, I think Duresta is very costly. I was told it is about $15,000 US.
Very expensive, yes sir.
Very expensive. So it's not, it's out of the
It's
range
out of
for-
reach for
Yeah,
most of us and our
definitely.
patients.
Definitely, and it works only for 3 months or 6
Yes,
months, whatever.
it's
it is.
not approved for second and third injections. and so
Second
on.
thing is, how do you know that the patient is, so you have a patient right in front of you and the glaucoma is progressing, okay, how do you know the patient is using the drops properly, whether compliance is good, or is there any way to check? Or you feel it progressing, you want to keep on adding one more drop, or say something else for the patient?
I think it's a fantastic question, and that's a dilemma which all of us would face as practitioners, ophthalmology, general ophthalmology, glaucoma, and otherwise. Glaucoma, we face it much more. The problem is how we try to check whether the patient is so-called adherent, and the new term for that is called adherence rather than compliance.
Yes.
So we want, if you are given a bottle which is to be used once a day, another bottle twice a day, and say come after 3 months, the patient will use one bottle only for both eyes for the next 6 months and not turn up after a year.
Correct.
So how do we check that? We casually ask the patient, how many bottles have you bought? How many times have you used the medication? Can we see your bottles? We see the bottle, you'll know how many times, how dirty it looks, or the cap is not there, or how many bottles have they purchased, any proof of some kind of purchase. We ask the relatives casually, have you seen them using the drops? Do they use it correctly or not? And then, of course, we look at the pattern of field loss, we look at the intraocular pressure, and we decide, we can make out from a lot of guesswork involved, and intuition and guesswork in regarding whether the patient is using it or not. If we strongly suspect that compliance adherence is a big issue, we simply switch to a surgical method. We offer a surgery rather than challenging the patient, confronting the patient, and saying the patient that you have not done this correctly, and they're not likely to, once you know this is a non-adherent patient, it's not likely to listen to you further. Offer a surgical solution. We now immediately opt for either an SLT or offer a MIGS as the surgical solution.
You still believe that the maximum medical therapy, 3 drug, 4 drug, nowadays I
Maximum
think 5
therapy.
drugs also is there. But I'm asking you because instead of pushing the patient and it's only going to benefit only the pharma companies, why don't we advise surgery for this patient
The
much
entire
earlier?
shift, the treatment in glaucoma is shifting towards early management, early intervention in glaucoma. It's no longer wait for medication, wait for progression, then do offer SLT, then offer surgery and so on. We straight away target glaucoma as a surgical disease. When you see cataract, we don't say, I'll give you some eye drops, come back after 6 months. So glaucoma also is slowly turning into a disease or a disease where you can offer SLT as a first choice. Patient does not opt for it, we offer medication. That's what I do now. We offer SLT. Then you have the choice of adding medication or giving medication. The patient does not want SLT. And if you find a minimum cataract or cataract which is operable, not the cataracts which we think or imagine there is cataract, when there is real cataract, you think of doing the cataract surgery and probably combine it with a mixed procedure. Mixed procedures work the best for mild and moderate glaucomas. So increasingly we offer MIGS as mild to moderate glaucomas with cataract surgery, and increasingly offer this maximum medication is usually never more than 2 bottles. Most people cannot use more than 2 bottles, at the most 3 or 4 medications, not more than that. That too in the interim period while you plan some other intervention.
Yeah, but one good thing is right now you're able to give 4 medications across 2 bottles.
Yes.
Things have
correct. That's why the combinations, the fixed combinations are
so
a real
maximum
good.
medical therapy is actually just 2 bottles, 3 doses, 1 BD and 1
How
OD.
is the efficacy?
Efficacy is good.
For example, the Trisopt,
Trisopt
good.
efficacy is fantastic. In fact, we were surprised with the results of the drug which was coming in.
I can fully
we were
agree with
surprised that why it was working so well. Then we found that most people who are given multiple bottles and giving separate bottles didn't work as well as the combination purely because of compliance.
Only.
No, especially when additive
Exactly.
effect,
Additive
and I've
effect,
seen
yeah.
my
Compliance is the main key factor here.
probably one of the most refractory glaucomas is neovascular.
Yes.
So neovascular glaucomas, I feel if Trisopt doesn't work, invariably I know this patient is going to end up
Yes.
needing surgery.
Yes.
That is how I take it.
Correct.
If I can bring the pressure down to at least 20s by
Anti-VEGF.
Trisopt, anti-VEGF, laser,
PRP,
he might be
anti-VEGF,
better. But if he doesn't,
Trisopt.
I tell him after anti-VEGF and laser, you'll end up needing a shunt. That's how I go.
Absolutely.
And nice to know that you people are also going to join us in injecting regularly in the eye.
No, that. Yeah, any questions from the audience on glaucoma? And glaucoma, I think, what about the direct SLT? If you have any experience, direct SLT has coming.
The Belkin's transscleral non-contact
Transscleral,
SLT
direct
is
SLT.
available now. It came from Israel. I think we're all awaiting the introduction in India. I think it may change the way we manage.
It's not new.
We have that
It's been
now.
there for a long time.
We have that now.
ECP is there for quite some time.
No, there's a new avatar in the sense we start doing it from the front of the eye. It's in the scope under the purview of our anterior segment. Make a limbal incision, inflate the posterior chamber, view it's a single function probe. It's a light source viewing endoscope with a laser delivery. I'm doing it for the last 1 month now.
But
We have
only,
it for a
only in
demo.
pseudophakic eyes you can do that.
You can do it pseudophakic, you can do it aphakic, and you can do it wherever vitrectomy is
Phakic also.
Phakic we generally avoid.
Ah, that's what.
Phakic you cannot.
Phakic you can't do.
Phakic, you will be touching the lens. No, ma'am. Actually, for cataract with glaucoma surgery, especially angle closure, the indication and publications have been on phaco with ECP. It's called endocyclophotocoagulation. What it does is shrinks the ciliary process. You are likely to open up the angle further than you would normally do with any other cyclophotocoagulation procedure. Endocyclo is controlled. You can
Control.
actually
This
see-
one is.
You can
this
see the
machine
burn,
is-
ma'am.
see ciliary processes, and you can do 180 or 270. I have started doing 180. Now last week I did about 2 patients, 270. IOP response has been fair. So I am
And
in
it
the learning
open-
curve.
Because it pulls the ciliary body
Instead
back,
of a
it opens
diode
up
which
the
is
angle
done-
also.
Diode which is done blind,
Yes.
you actually see ciliary processes. I think the pars plana route has been popular among retinal surgeons for quite some time. But now it comes under the purview of our retinal surgeons, anti-segment surgeons also.
Okay, we'll go to the next